everyone remember, please put in your details to receive CME credit. And let me get to the information on what's coming up. We have one more grand rounds for this calendar year next week. Then we have a break for New Year's and Christmas. And then we'll have a return back to the theme of cardio-oncology with Susan Dent. So we're hitting that theme pretty hard in the last few weeks. And then we'll have two wonderful presentations from our fellows coming up. So with that, I'm just going to ask Dr. Ahmad to introduce Dr. Noria.
Thank you so much, Eric. Brings back good memories from hosting Grand Round. So it is my great honor to welcome Dr. Noria back to Yale. Dr. Noria has an impeccable pedigree. She graduated from Harvard College and Harvard Medical School. She did her medicine residency at Yale, where she was chief resident with our own Dr. Arya Mani. And she decided to become...
With Margaret Pisani.
Oh, with Margaret Pisani. Yeah. She decided to become a heart failure doctor because she worked with Dr. Woody Lee. Exactly. And I think there's a lot of people who share that. Then she moved back to Boston, where she trained at the Brigham, and she stayed there since. On a personal note, Anju was the attending during my first cardiology rotation as an intern. As I progressed from trainee to a new attending now 8 years into my job, I'm amazed how my perspective on who I regard highly in the field has evolved. I used to look up to people who published a great deal and were considered thought leaders. However, over the years, I have come to see how less that the published literature in the microcosm of cardiology truly impacts care at the bedside. I realize that the people who truly matter, on whose shoulders the entire healthcare system rests, are those who you would trust to take care of your family members. These individuals are few and far between and rarely get the acclaim they deserve. Anju is exactly that kind of doctor. She was the one who would come in at midnight if the patient was not doing well. She knew her medicine way beyond citing studies and truly cared about the patients in a way that few of my mentors have. If you asked me as an intern what I wanted to be, I would have said I would be a well-known clinician investigator. If you asked me today, I would say I would want to be more like Anju Noria. Thank you.
Well, Tariq, thank you for that very, very nice introduction. I would say I feel the same way about Woody Lee. So it all comes down the generations. It's very nice to be back, especially, do I just click this to move this forward or? Okay, all right, perfect. It's very nice to be back. As I was looking through my old photos, I found this picture of Rosemary Fisher, who was the program director when we were here, and the other chiefs in my class. And two things I reflected upon. One, we all looked much better at that time. And the other, that as you can see from the joy on our faces, we really cherished and enjoyed our years here. And it's, what happened?
Thank you, Alexander. We'll fix that here in a second.
Yes. Oh, I'm sure to me. Yeah, but they're not seeing the slides. So say share to me. Okay. Okay. All right, that's fine. Yeah.
That's good?
Yep.
All right. Anyway, I'm very, very glad to be back and to see all the familiar faces who are sitting here. So these are my disclosures. Over the next 40 minutes or so, I was going to provide a brief overview of the cardiovascular complications that are seen in cancer patients. And rather than providing a comprehensive overview of the field of cardio-oncology, I was going to touch upon some of the old cardiotoxicities related to anthracycline use and mediastinal radiation, and then also talk about immune checkpoint inhibitors. And in doing so, hopefully talk about some of the clinical research that we have done in these areas. So as cancer diagnostics and therapy have improved, the number of people who are surviving cancer has continued to grow. It is estimated that currently there are about 18 million cancer survivors in the US, and this number is supposed to grow to 26 million by the year 2040. But more importantly, how do you, the keyboard might be better? Okay, perfect, because I was gonna say animation isn't gonna work. But more importantly, still not working. That's okay.
This arrow?
It hadn't changed since you were a resident.
Oh.
Oh.
We had good AB then. No, I'm kidding.
If I go. I click once here.
Yeah,
Then if
okay,
you try the
now it
arrow?
worked. Okay, yeah, now it worked. Okay.
I think I would just, yeah.
All right, perfect, thank you. But as you can see, majority of these people are over the age of 65. And so it's not surprising that cancer and cardiovascular disease coexist in many of our survivors. And if you look at the causes of non-cancer related death in cancer survivors, you can see here, there's no pointer either, right? Okay, does this point? Yeah. You can see here in the red that cardiovascular disease is the single largest cause of non-cancer related death. And this is true even if you are very early into your cancer journey or several years later. So why is this the case? As I mentioned before, they're both diseases of the aging population. Both cancer and heart disease share many risk factors such as smoking, obesity, physical inactivity, etc. And in fact, there was a very nice study published in JACC Cardio-Oncology where they looked at patients based on their ASCVD risk. And they found that the higher your ASCVD risk, the greater your likelihood of incident cancer. Furthermore, we know now that there is shared biology. In fact, a lot of people in this room are working on some of these mechanisms. We know that inflammatory disease contributes to both cancer and heart disease. And this was shown very nicely in the CANTOS trial, where they gave canakinumab, which is an IL-1 beta inhibitor, and they looked at the outcomes in patients who had an MI and elevated CRP as a marker of inflammation, and they found that you had a decrease in recurrent cardiac events. But importantly, what they found was that canakinumab also reduced incident lung cancer in a dose-dependent fashion, again suggesting that inflammation is a big driver of both disease processes. There has also been a growing interest in clonal hematopoiesis of indeterminate potential, or CHIP, and I know that Jennifer here has been doing extensive research in this area. But it has been known for a long time that somatic mutations in cells that lead to malignancies in the myeloid lineage have also now been associated with an increased risk of cardiovascular events, primarily with MI, where TET2 and ASXL1 mutations have been associated with an increased risk of MI. DNMT3A has also been associated with an increased risk of heart failure. And increasingly, we're learning that these mutations are associated also with aortic sclerosis and stroke. So again, the same mechanisms seem to be promoting both cancer and heart disease. And last of all, what we are most interested in the cardio-oncology clinic is cardiotoxicity that is associated with cancer agents. So this is just a cartoon to show the various cardiac dysfunctions that can happen as a consequence of cancer therapy. You can get ventricular dysfunction, primarily with drugs such as anthracyclines. You can get hypertension, primarily with tyrosine kinase inhibitors, particularly VEGF inhibitors. You can get ischemia, either in the form of vasospasm with 5-FU and capecitabine. BCR-ABL inhibitors like nilotinib and ponatinib have been associated with acute vascular events. I have an echo. Okay, all right. And then there's also early accelerated atherosclerosis with radiation, which I'll talk about later. Several oncology drugs can also lead to both brady and tachyarrhythmias. Drugs such as crizotinib have been associated with bradyarrhythmias, and then drugs such as ibrutinib, which belong to the category of Bruton tyrosine kinase inhibitors, have been associated with atrial fibrillation and ventricular arrhythmias. And then cancer by itself, as well as several cancer therapies, have been shown to promote venous thromboembolism, and PE. So shifting gears to talk a little bit about anthracyclines. Anthracyclines are some of the oldest drugs that have been associated with cardiotoxicity and probably amongst the best studied. It has been known that anthracyclines cause a dose-dependent cardiotoxicity with an inflection point of about 250 milligrams per meter squared, such that anybody who gets doses higher than that is at higher risk of developing cardiotoxicity. There are many mechanisms by which anthracyclines can cause cardiotoxicity. Primary amongst these is that they lead to an increased formation of reactive oxygen species that ultimately lead to mitochondrial dysfunction, energy depletion, and myocyte cell death. Anthracyclines also bind to topoisomerase 2 beta, thus creating permanent double-stranded breaks in DNA, which can also lead to myocardial dysfunction and cell death. And increasingly, we are understanding that there are many polymorphisms that can change the way anthracycline enters the myocytes and exits the myocytes, how many toxic metabolites are cleared from the myocardium. And then our own group, along with Cricket Seidman's lab, has shown that patients who have titin cardiomyopathy or mutations in titin can be prone to developing anthracycline cardiotoxicity as a second hit phenomena. So with all of this, in adults, it has been shown with prospective studies that majority of the cases of anthracycline toxicity happen within the first year after anthracycline exposure. And based on this, the recent 2022 ESC guidelines have really focused on surveillance with echocardiography within that first year after completing anthracycline treatment. And the frequency with which you perform echocardiograms is really based on the patient's underlying risk for developing anthracycline cardiotoxicity, which depends upon dose, their pre-existing cardiovascular risk factors, and whether or not they have underlying cardiovascular disease. In children, however, it is known that anthracyclines act synergistically with chest radiation to increase the risk of cardiomyopathy. Again, there is a linear relationship between anthracycline and radiation dose and the development of cardiomyopathy. And unlike adults, this risk continues to accrue over the lifetime of the child. As we were seeing these patients clinically, we were following the Children's Oncology Group guidelines. And as you can see, these guidelines recommended echoes based on the age at which the child was exposed, whether or not they got anthracyclines, whether or not they got radiation, and the dose of each of these that they were exposed to. And the guidelines really recommended echoes either every year in high-risk patients or every 2 to 5 years in intermediate and low-risk patients. And as you can imagine, this imposed a significant burden not only on the children who had survived cancer, but also on the healthcare system. And as I was seeing these patients in my clinic when I started out, I felt like we were really doing a lot of unnecessary echocardiograms in these patients. So I collaborated with the Perini Clinic at Dana-Farber and researchers at the Harvard School of Public Health. And we created a model to try and figure out what was the optimal screening strategy for these patients. Because there is a huge latency in the development of cardiomyopathy, it's very hard to do a systematic clinical trial to figure out how often these patients should have surveillance. So we used the Childhood Cancer Survivor Study, which is a study of, at that time, 14,000 children who had been diagnosed with cancer before the age of 20 and had survived into adulthood. And we used the data from that study to estimate the risk of developing asymptomatic LV dysfunction. We then used the Framingham data to estimate the risk of progressing from stage B to stage C heart failure and then dying as a consequence of heart failure. We used the solved data to try and estimate the efficacy of ACE inhibitors and beta blockers in people with asymptomatic LV dysfunction, and then derived cost estimates for visits, echoes, and medications, and then used all of these to calculate the ICR for different surveillance intervals based on the baseline anthracycline exposure. And what we found was that if you use $100,000 as the cutoff for what is considered cost effective, which is shown in this line of unity, anything at this end of this line is a cost-effective interval. And if you look really for people who had low exposure, we found that maybe screening every 10 years, or in fact, no screening was the most cost-effective strategy. If we looked at high-risk individuals, namely those who got high doses of anthracyclines, we found that really any interval more than 2 years apart was felt to be cost-effective in this group. So based on this, our recommendation was that if you got low-dose anthracyclines, you should get an assessment every 10 years or never. And if you got high dose, it should be every 2 to 5 years. And actually, believe it or not, another group from LA published a similar study at the same time in the same Annals of Internal Medicine article. And essentially what they found was that they had similar results. And based on this, we were able to change the children's oncology group guidelines such that for very low risk groups, they moved to no screening. And for moderate groups, they moved to every 5 years. And high risk groups, they moved to every 2 years. Recently, we did another study where we also incorporated radiation exposure into the model. And now we had many more patients, about 25,000 in the children's survivor group. And we also had 3,000 prospectively studied patients from the St. Jude's lifetime cohort. And again, we found that for people who were low risk, you really recommended no screening. For intermediate risk, it was every 5 to 10 years. And for high risk, it was every 2 years. And again, the International Guidelines Harmonization Group just came out with their new guidelines, and they actually adopted a similar lower screening interval in these childhood cancer survivors. So clinically observed things actually led to an impact on how much screening we are doing and what burden we are imposing upon these patients. We also wanted to define what constitutes cardiotoxicity. So I was part of the International Cardio-Oncology Society guidelines, where they came up with a framework for defining anthracycline cardiotoxicity. And they divided people into asymptomatic and symptomatic chemotherapy-related cardiotoxicity. And the category that I would like to bring to your attention is this category of mild asymptomatic cardiac dysfunction. So these were people who had preserved LV function, but had a new decline in global longitudinal strain of greater than 15% from baseline, or had a new rise in cardiac biomarkers, either in the context of chemotherapy or shortly thereafter. And the hope was that if we could focus on this group, that perhaps some sort of intervention early on would actually change the outcome of eventually going on to develop overt cardiotoxicity in this population. Thus far, unfortunately, the few studies that have been done in this space have not shown any impact of intervening in this group in terms of preventing eventual cardiotoxicity, but this remains an area of study. The things that do seem to have an effect on cardioprotection are, one, using a liposomal formulation of doxorubicin rather than standard doxorubicin. Again, because liposomal doxorubicin is a much larger molecule, it's able to penetrate the tumor, but is less able to penetrate healthy tissues. And therefore, you almost have a threefold lower risk of cardiotoxicity if you use this agent instead of standard doxorubicin. And then another agent that has been very successful is dexrazoxane. This is an ion chelator. It also shuttles topoisomerase 2 beta out of the system so that anthracyclines can't bind to it. And when given concomitantly with anthracyclines in this study in women with breast cancer, you found that the cardiac event-free survival was much better in the patients who got dexrazoxane compared to those who got anthracyclines alone. And importantly, in this study, they showed that if you gave the dexrazoxane after the patients had already received 300 milligrams per meter squared of anthracyclines, you were still able to prevent the development of cardiotoxicity. So based on this, the FDA actually currently only approves dexrazoxane for those people who have gotten 300 milligrams per meter squared of anthracyclines and are going to get further treatment with anthracyclines. The reason that dexrazoxane has not caught on within the oncology community is that the way that it works is by interfering the very mechanisms by which anthracyclines exert their anti-cancer effects. And there was a lot of concern that giving these drugs would either reduce the efficacy of anthracyclines and or promote late onset secondary cancers. And there was a pediatric study that was done several years ago in 2015, where they took children with ALL or non-Hodgkin's lymphoma and treated them upfront with anthracyclines alone, shown here in the blue, or anthracyclines plus dexrazoxane. And what they found was that at the completion of anthracycline therapy, the nadir in EF was less in the dexrazoxane group. And if you followed them 3 years later, the dexrazoxane group was more likely to come back to a normal EF compared to those children who got anthracyclines alone. But importantly, they did a 10-year follow-up of these patients, and they showed that, in fact, the cancer-free survival was equivalent in the two groups. And importantly, there was also no increase in the incidence of secondary cancers. So again, with this data, we are hopeful that the uptake of dexrazoxane will grow in this patient population. People have also looked at neurohormonal blockade. There have been many small studies looking at the effect of upfront ACE inhibitors or beta blockers as a strategy to prevent cardiotoxicity. Again, these have been small studies with varying results. And we had done this meta-analysis where we showed that even though the point estimate was favorable, if you look at the heterogeneity in all of these trials, you can see that we really have no conclusive data about whether or not neurohormonal blockade is cardioprotective. There has also been recent interest in statins, with the logic being that because they're anti-inflammatory, they may have a cardioprotective effect in patients receiving anthracyclines. This was a study done out of Wake Forest, where they gave patients getting anthracyclines, atorvastatin 40 milligrams daily upfront, and continued it for 2 years. And they looked at EF by MRI at the end of therapy and then 2 years later. And they found no difference between the atorvastatin-treated patients or the placebo-treated patients. A similar study out of Canada looked at the EF change after 6 months. And again, they found no difference between the statin-treated patients and the placebo-treated patients. However, there was a study done at Dana-Farber and MGB, where basically they took lymphoma patients who were getting high-dose anthracycline chemotherapy and randomized them to atorvastatin 40 or placebo. And they found that the incidence of cardiotoxicity, defined as a greater than 10% decline in EF to less than 55%, was significantly lower in those patients who got statins, 9%, compared to 22% in the placebo group. So again, based on this, the ESC guidelines give a 2B recommendation to statin use because there isn't data that is consistently showing a benefit of statins in this patient population. So as you can see, there are still several gaps in our knowledge about anthracycline cardiotoxicity. We still don't have a good sense for who is truly at risk. We all see young women with breast cancer who are getting 240 milligrams per meter squared of anthracyclines and still develop cardiotoxicity. For childhood screening, we have reduced the interval, but for a child who is 40 and has not had any cardiotoxicity, do we really need to continue monitoring them for the rest of their life? Or is there a point at which we can say we've done enough? We're still looking for the holy grail to prevent cardiotoxicity in the first place. And then once people develop cardiotoxicity, we treat them the same as we do anybody else with heart failure. But are our standard GDMT equally effective in these patients is a question that remains to be answered. The other area that we have contributed to and have been interested in is radiation-associated cardiovascular disease. So radiation therapy, as you know, is used in about 1 million patients per year. It's used for a variety of cancers. And if it involves the chest, it is particularly prone to developing cardiac complications that occur at an average of about 20 years after completion of treatment. The primary mechanism is that you get endothelial damage. This leads to expression of adhesion molecules, recruitment of neutrophils and macrophages, release of cytokines that ultimately promote fibrosis and also promote acceleration of traditional mechanisms of atherosclerosis. And radiation can cause many complications, including accelerated coronary artery disease, valvular heart disease, both in terms of stenosis and regurgitation, You can get pericardial constriction and myocardial restriction. You can get a syndrome of inappropriate sinus tachycardia and high degree AV block. And importantly, many patients can have all of these together. So as I had mentioned before, in all individuals, children and adults, radiation has a linear dose-dependent cardiotoxicity, where for every 1 gray increase in the mean heart dose, you have a 7.4% increase in your risk of having a cardiovascular event. And this has been shown consistently in both Hodgkin lymphoma survivors, as well as in breast cancer survivors receiving left-sided breast radiation. We wanted to examine this relationship between radiation dose and cardiovascular events more closely. And we decided to look at a group of patients with non-resectable lung cancer who tend to get very high doses of radiation on the order of 50 to 66 gray, and tend to have a very high cardiac event rate in a very short follow-up period. And what we did was we looked at 701 patients who were treated with radiation for non-resectable non-small cell lung cancer at the Brigham, and we assessed the relationship between the mean heart dose and the incidence of cardiovascular events at 2 years. And what we found was that, like non-Hodgkin's lymphoma and breast cancer, there was really a linear dose-dependent relationship between mean heart dose and major adverse cardiovascular events, as well as all-cause mortality. Then we wanted to dig into this a little bit further and say, are there specific substructures within the heart that make you more susceptible to developing cardiovascular events? And we took the CTs that these patients were having at baseline to map their radiation therapy and used manual contouring techniques to basically outline the different cardiac structures, including the individual coronary arteries. And then we used ROC analysis to really see what dose and to what proportion of these coronary artery territories placed you at highest risk for developing adverse cardiovascular events. And what we found was that if your LAD got more than 15 gray of radiation to greater than 10% of its volume, you were at highest risk for developing cardiovascular disease. We then looked at this in a smaller cohort of patients using PET imaging, where we wanted to see what radiation did to microvascular blood flow. And we took 35 radiation patients and compared them to age, gender, and risk-matched control patients who were also undergoing PET. And we found that global myocardial flow reserve was significantly decreased in the radiation cohort compared to the control patients. And again, when we looked at the different coronary territories that were affected by radiation, we found that the inverse relationship was most significant in the LAD distribution. So again, collectively, these data show that if your LAD is involved in the radiation field, you have the highest risk of having adverse cardiovascular events. Additionally, in our lung cancer cohort, we also had the benefit of trying to look at the impact of cardiovascular risk factors and underlying cardiovascular disease on the risk of developing adverse cardiovascular events after radiation therapy. So in our 700 patient cohort, about a third of the patients had pre-existing cardiovascular disease. And the remaining 2/3, even though they didn't have pre-existing heart disease, had a Framingham risk score of about 15, suggesting that they had a very high prevalence of underlying cardiovascular risk factors. And we looked at the interaction between radiation dose and cardiovascular disease. And what we found was that the overall incidence of adverse cardiac events was significantly higher in those patients who had pre-existing heart disease. But if you look at the additive effect of radiation, it was much more evident in those people who didn't already have heart disease, but had underlying cardiovascular risk factors. And in fact, this was true even if you looked at the LAD dose, where again, if your LAD was involved and you had pre-existing heart disease, you had an increase in cardiovascular events if you got radiation. However, if you had no pre-existing heart disease, the effect of radiation was significantly higher. So collectively, what these data showed us is that, first of all, reducing the mean heart dose, especially the LAD dose, can significantly impact cardiovascular events in patients treating with radiation therapy. And especially with the advent of AI, our colleagues in radiation oncology can now actually contour the heart and even the substructures such that when they plan to give radiation therapy, they can try to avoid the LAD, especially if the cancer is not spatially located very close to the LAD. The other thing that these data show is that optimizing underlying cardiovascular risk factors can also have a significant impact on improving cardiovascular outcomes in patients being treated with radiation therapy. And we actually tried to examine this a little bit further. So in our high-risk cohort, only 66% of those patients who were eligible for statin therapy were on statin therapy. And when we looked at the effect of radiation based on whether or not they were on statin therapy, we found that if you weren't on statin therapy and you got 10 gray of radiation, your cardiac event-free and overall survival was significantly lower if you got radiation therapy. However, if you were on a statin, that detrimental effect of radiation therapy was significantly attenuated. Again, suggesting that treating cardiovascular risk factors can have a significant impact on cardiovascular outcomes in these patients. And in fact, this is a missed opportunity because all of these patients have CT scans, either for staging, for planning, et cetera. And really all that you as the cardio-oncologist or the oncologist have to do is look and see if they have coronary calcification on their CT. And if they do, then even if you don't have a lipid profile or anything available to calculate their ASCVD risk, you could start them on statin therapy and significantly impact their outcomes. And currently, we're participating in an NIH-sponsored trial that is being run by Bonnie Key out of UPenn. And essentially, she's looking at different biomarkers as well as imaging markers to try and create a phenotypic profile that will help us not only understand the mechanisms by which radiation causes cardiovascular disease, but also help identify which patients might be at highest risk for developing cardiovascular disease. And we at the Brigham are the core lab for the PET imaging in this study. So not only do these patients have a high risk, but some of these patients, especially patients like Hodgkin lymphoma survivors who tend to get very high dose radiation at a young age, tend to get heart disease at a much earlier age, about a decade before their age-matched controls. And when they get heart disease, they tend to have much worse outcomes. And we showed this in the Young MI registry. This is a registry of Mass General and Brigham patients who present with an MI before the age of 50. And as you can see here, Hodgkin lymphoma patients who received radiation had a much higher mortality, both from a cardiovascular and all-cause mortality, compared to age, gender, and risk-matched control patients. Why is this the case? So we actually, along with people at Cleveland Clinic, looked at the surgical outcomes in radiation patients. And we found that if you match patients by Euroscore or STS score, radiation patients who are having first-time surgery, shown here in blue, have a significantly decreased survival. And if they have redo surgery, that impact of radiation is even higher. What about if they have PCI? So this is a study out of Cleveland Clinic again, and they suggested that radiation patients have worse outcomes compared to non-radiated patients after PCI. But at the Mayo Clinic, they actually divided this into cardiovascular and non-cardiovascular mortality, and they found that PCI was equally effective in terms of reducing cardiovascular mortality, but radiation patients tend to have a higher non-cardiovascular mortality after PCI. So again, based on these data, if you have a person with isolated coronary artery disease or discrete lesions, at least in our practice, we prefer a non-surgical approach to intervention compared to coronary artery bypass surgery. We also looked at outcomes after valvular surgery. This was a small cohort, again, from the Brigham, where we looked at TAVR versus surgical valve replacement for aortic stenosis. And overall, there was no difference in outcomes between these two strategies. However, if you divided them up by their surgical risk, low-risk patients seemed to do equally well, but intermediate or high-risk patients did much worse after surgery compared to TAVR. And in fact, we looked at the SDS database to look at individual complications after TAVR in radiated patients. And we found that in general, TAVR was favorable compared to surgery in all outcomes, except for the need for permanent pacemaker and the risk of post-intervention stroke. And this was true regardless of which era TAVR was done in these patients. So again, based on this, if we have a patient who has isolated aortic stenosis with or without coronary artery disease, we prefer TAVR with PCI rather than surgery. We also found in our work that in general, patients who've undergone cancer therapy, whether it be chemotherapy or radiation, tend to have much lower functional capacity compared to community controls. And this difference is almost 7 mg/kg per minute, which is a lot if you think about in terms of the functional capacity objectively. And in fact, we looked at 1,600 patients who had undergone stress testing at the Brigham for various reasons, and these were all cancer survivors. And we found that patients in the lowest tertile of exercise capacity had a much higher all-cause cardiovascular and cancer-related mortality. So we wanted to investigate why this might be the case. And particularly in our radiation patients, we found that a lot of them said, I'm okay on flat ground, but if I have to do an incline, I can't breathe, right? Or I can walk, but I can't run. And we wanted to see why that might be the case. And what we found was that a lot of them had inappropriate resting sinus tachycardia. And in fact, when we looked at the proportion of people who had a resting heart rate greater than 80 beats per minute, we found that this was significantly higher in patients who had undergone radiation compared to age and gender matched controls. And not only did they have a high elevated resting heart rate, they also had abnormal heart rate recovery after exercise. Many of them had a blunted blood pressure response to exercise, reduced heart rate reserve, all markers of dysautonomia as a consequence of radiation therapy. And in fact, the longer you survive from radiation therapy, the higher the likelihood of having autonomic dysfunction in these patients. And importantly, what we showed was that if you had autonomic dysfunction, you had a lower exercise capacity, primarily because of reduced heart rate reserve in these patients. And importantly, those patients who had abnormal heart rate recovery had a 5-fold higher risk of mortality. So we wanted to see how we could change this to try and improve the exercise capacity of these patients who came to our clinic. And many of them are intolerant of beta blockade and calcium channel blockers, either because they don't have enough blood pressure or because they have underlying radiation-induced lung disease. And so we tried to look at ivabradine. Ivabradine, as you know, is an inhibitor of the funny channel, and the funny channel in the SA node is important for mediating the communication between the autonomic nervous system and the response of heart rate in the heart. And what we did was we took survivors of lymphoma who had received chest or mantle radiation more than 10 years prior to the study. They all had to have a resting heart rate greater than 80 beats per minute on Holter monitoring. Some of them were on low-dose beta blockers, so we stratified according to that. And we randomized them to ivabradine or placebo for 6 weeks. And we measured a Holter, a standard Bruce exercise test, and an SF-36 quality of life questionnaire at the beginning, and then 6 weeks after therapy. We had intended to enroll 60 patients, but unfortunately during COVID, Amgen cut our funding. So this was only a pilot study of 23 patients. But in those 23 patients, we found that ivabradine successfully lowered their resting heart rate, both at the average heart rate, the minimal heart rate, and the maximal heart rate. If you looked at Holter parameters of autonomic function, they all improved with ivabradine compared to placebo. But unfortunately, there was no change in exercise duration, presumably because you brought down both their basal heart rate and their peak heart rate, so you actually didn't affect heart rate reserve in this population. And even more importantly, there was absolutely no change in any quality of life parameter. Now, arguably, this is a small group, and maybe we didn't study them long enough. We were underpowered for this outcome, but at least the preliminary data, we were disappointed that we were unable to find a strategy to help these patients feel better. So again, there are many unanswered questions in survivors of chest radiation exposure. How do you best assess who is at risk? How do you best modulate this risk? Do you start them on statins from the day that they get radiation? Do you wait till they have coronary calcification? At what point and what drugs do you use? And are statins equally effective in patients whose primary mechanism is fibrosis? And then once they have CVD, how do you optimize their cardiovascular outcomes? Lastly, I would like to talk about immune checkpoint inhibitors. As you all know, tumor antigens are expressed in the context of MHC to the T cell receptor. This leads to T cell activation, and you have tumor cell death. There are regulatory molecules that are present on the T cells, both in the periphery and in the tumor microenvironment. And these interact with ligands on antigen-presenting cells or the tumor cells to dampen the immune response. And in fact, tumors often overexpress these ligands as a way to trick the immune system. And the way that immune checkpoint inhibitors work is they are antibodies against these regulatory proteins or their ligands. And by blocking this regulatory process, they allow the immune system to attack the tumor in a more aggressive fashion. People who get immune checkpoint inhibitors can have collateral damage to a lot of different organs, varying from the skin, the lungs, the colon, the liver, etc. The heart can also be involved, but is relatively rare. About 1% of these patients develop immune checkpoint inhibitor myocarditis. There have been many mechanisms that have been proposed. Some people argue that the immune checkpoint inhibitor recognizes unrelated antigens on bystander organs. You may have preformed antibodies that get amplified as the T cell response is activated. You have inflammatory cytokines that can result in damage to other organs such as the colon, or the normal cells may express some of these regulatory molecules such as CTLA-4 on their surface, and then the immune checkpoint inhibitor has off-target toxicity that is directly related to that organ. We were part of a registry initially that included 35 cases of immune checkpoint inhibitor-mediated myocarditis. They found that the median time for presentation was 30 days, and majority of the cases happened within the first 3 cycles of immunotherapy. It was more common with dual ICI therapy, but the incidence was about 1% if you had single ICI therapy, and about 2% if you got both 2 ICI inhibitors. Most patients presented with EKG abnormalities of some kind, but the ones that were pathognomonic were complete heart block requiring pacemaker placement, new left bundle branch block, new right bundle branch block, and then in fulminant cases, you could get both ventricular and atrial arrhythmias. More than 90% of patients had an elevation in troponin. EF was not necessarily impacted in all of these people, and people may or may not have an elevated NT-proBNP. And at least initially, there was a very high rate of major adverse cardiovascular events, consisting of cardiovascular death, cardiogenic shock, cardiac arrest, and complete heart block requiring permanent pacemaker placement. And troponin was felt to be the single best marker of predicting who was more likely to develop an adverse event. The higher the troponin, the higher the likelihood of having an adverse event. As the registry grew, we tried to look at MRI criteria for myocarditis as a way to predict who was developing ICI myocarditis, and we compared this to endomyocardial biopsies that showed tissue evidence of ICI myocarditis. And when we used the traditional Lake Louise criteria that looked at LGE, or edema by T2 weighted stir imaging, or EF less than 50, we found that they were not very predictive when you compared them to histology. However, when you started using parametric criteria or the modified Lake Louise criteria, they found that most patients had at least one of the modified Lake-Louise criteria, and almost half the patients had both Lake-Louise criteria. And in fact, if you had abnormal T1 relaxation time shown here in the blue, they were highly predictive of your likelihood of developing a major adverse cardiovascular event. Similarly, in other studies, we showed that if you have abnormal global longitudinal strain on echo, that also predicted your likelihood for developing adverse cardiovascular events. So based on this, the International Cardio-Oncology Society came up with diagnostic criteria for making the diagnosis of ICI myocarditis. So either you had to have a histologic diagnosis on endomyocardial biopsy, and these biopsies often look like grade 3 transplant rejection, where you have lymphocyte infiltration, myocyte necrosis, and cell death. Otherwise, if you didn't have an endomyocardial biopsy, you had to make a clinical diagnosis, which was an elevated troponin and either both modified Lake-Louise criteria on CMR, or you could have a CMR that was suggestive, meaning it had one criteria but not both, and either a clinical syndrome, ventricular arrhythmias or new conduction system disease, a decrease in your EF, or other immune-related adverse events such as myositis or myasthenia gravis. And about 25% of people who present with ICI myocarditis will have one of those two comorbidities with them. So the current algorithm is that if you see a patient where you suspect ICI myocarditis, you should get an EKG, you should get biomarkers, you should get an echo with GLS. If the person is stable, make sure you rule out alternate etiologies such as acute coronary syndrome, get a CMR with parametric mapping. If it's normal, but you still suspect it, then look for other diagnostic criteria. If you don't have them, then you should proceed to an endomyocardial biopsy. And the reason for this is that you really don't want to deprive someone of life-saving ICI therapy unless you're sure that they have the diagnosis. If it's an unstable patient, they should go to the cath lab where they can get all of this done in one shot, including an endomyocardial biopsy. And that way you can confirm or exclude the diagnosis. We also wanted to look at treatment. So most of these patients, when they come in, get high-dose steroids, 1 milligram of Solumedrol daily for 3 days. And then if their enzymes start to go down and they clinically improve, you transition to 1 mg per kg of prednisone per day. So we divided up our cohort into people getting 500 to 1,000 milligrams of prednisone, 60 to 500, and then less than 60 milligrams of prednisone per day. And we found that the higher the steroid dose used, the lower the likelihood of major adverse cardiac events. Similarly, timing also seemed to matter. So if you gave it within the first 72 hours, patients had a much better outlook compared to getting it later. And if you use the combination, it seemed that timing mattered more than dose. So treating them early with some steroid was better than necessarily giving high-dose steroids. So based on this, the current algorithm is that if a person comes in with suspected ICI myocarditis, you should stop the ICI, start high-dose Solumedrol right away, and then do the workup to confirm the diagnosis. If the workup turns out to show that they don't have it, then you can stop the steroid therapy at that point. If you have a patient that's responding, as I said before, you would transition them to prednisone. If they're not responding, you often have to add a second immunosuppressive agent. We tend to use mycophenolate, but other people have also used things like abatacept, alemtuzumab. And then in fulminant cases, you often treat them like transplant rejection with ATG, et cetera. We recently did a study of 160 patients who were admitted to Mass General and Brigham, and we wanted to see, has the contemporary outlook of ICI myocarditis changed now that we know so much more about how to diagnose and manage this disease? And in these patients, we found that 28 patients were fulminant and 96 had what we would call a smoldering low-grade myocarditis. And actually 36 patients did not meet the diagnostic criteria for myocarditis. And if you looked at the survival of these patients or cardiovascular mortality, you found that it was only about 30% in the fulminant cases and about 10% in the non-fulminant cases, suggesting that the outlook has improved in modern times compared to the originally reported mortality that approached 50% in this disease. But more interestingly, if you looked at their overall one-year survival, it really was not different whether you had fulminant, smoldering, or a negative diagnosis, but a suspicion of ICI myocarditis. And what we don't know is this because we are depriving these people of good cancer therapy and now they're dying of progressive cancer? Is the immunosuppressive therapy that we're giving to turn off the myocarditis actually now accelerating the cancer, right? And importantly, even in the negative cases, only 40% got ICI therapy again. So once you suspect it, there is this knee-jerk reaction to just stop ICI therapy permanently and never put it back on these patients. And in fact, we may be doing a disservice by sort of creating this fear of ICI myocarditis. We're actually promoting the cancer death of these patients. So again, there are many unanswered questions, even for ICI cardiotoxicity. We really don't understand who is at risk other than those who get dual ICI therapy. And I know that there is significant work being done by Lauren and others here to try and look at that. What is the optimal agent to treat ICI myocarditis? Should be giving these people high-dose steroids, and are we actually doing harm in that case? What about the smoldering non-fulminant myocarditis? Should we be hitting them that hard? And can we think about reintroducing ICI therapy in these patients? And what does our treatment do to cancer progression in these patients? So in an attempt to answer this, we're actually involved in a multi-center trial called the Atrium trial. This is a trial that is taking people with ICI myocarditis based on the ICOS criteria and randomizing them to the CTLA-4 agonist abatacept in addition to corticosteroids versus corticosteroids alone. And even though the primary endpoint is major adverse cardiovascular events, in the secondary endpoints, we're looking to see if you can shorten the duration of steroids, if you can reduce the extent of damage to the heart, can you truncate the degree of biomarker elevation, et cetera, in these patients, and also what happens to their cancer survival if they get abatacept. And then there is a rescue arm of the trial where for people who present with fulminant myocarditis, they get open label abatacept and they will be compared to historical controls. There's also increasing evidence that people who get ICI therapy for a long time have chronic inflammation, and this chronic inflammation increases the progression of atherosclerosis, especially in those people who have pre-existing cardiovascular disease. And this has been shown in this study where they compared people getting ICI to people getting no ICI. And they found that the risk of all cardiovascular outcomes was significantly increased, specifically myocardial infarction, the need for coronary revascularization, and ischemic stroke. And in a small study of 40 patients, Tom Nealon from MGH took patients who were getting ICI therapy for melanoma, and he took people who had had a CT a year before they started immunotherapy, had a CT at the time of immunotherapy, and then a year later. And he looked at the rate of progression of atherosclerosis with coronary CT angiography. And what he found was that, in fact, the plaque volume significantly increased after ICI treatment compared to before ICI treatment. And we're now involved in a prospective study at the Brigham, MGH, and Dana-Farber, where we're taking patients who are getting started on ICI therapy for melanoma, doing a CT coronary angiogram, biomarkers, and other proteomic markers at the beginning of ICI therapy, and then 2 years later to look to see whether this actually bears out and whether there may be a benefit from intervening on these people to try and prevent this adverse outcome. So in summary, cardio-oncology is a very young and evolving field. There are significant toxicities, and although novel therapies are very exciting, the old therapies still continue to have a significant impact on the life of these patients. There is very limited evidence to guide surveillance and management, and really most of the recommendations are based on expert consensus. And significant research is needed to better understand the shared biology between cancer and heart disease, and also to improve both outcomes in our patients. Thank you for your attention. No problem.
Thank you, Anju, for a wonderful talk and kind of reviewing that. I'm curious about the immune checkpoint inhibitor therapy reapplication in patients. And I'm curious about your experience with that. And, for those who have reintroduced that therapy because of cancer progression, how would you imagine modifying monitoring and trying to ensure that you can kind of get these patients through that therapy the second time?
So I would say we haven't done it in too many people. And the only cases where we've done it is really where the patient has absolutely no other therapeutic alternative and they're young. And so they're not ready to just move to a palliative mode of care. In those patients, we have absolutely not allowed dual ICI therapy again. We've asked them to give single therapy, and usually we've switched the agent, even though there's no data to suggest that that does anything. But the logic is that maybe if there was an epitope that was shared or, some antigen that was expressed, that was recognized, then maybe switching the agent would be helpful. I think for those patients in whom we've given it, and again, the numbers can be counted on less than one hand, I would say that we have monitored their troponin very closely at the time that we have reintroduced it. And we've never reintroduced it until their troponin came down. And at that point, we've kind of monitored very closely with each cycle to make sure that they don't have a recurrent rise in troponin. And if they've tolerated it, then we've kind of continued to do that with every cycle. And if they survive like the first 3 cycles, then we're okay. And we've become less, anal. But I would say that the oncologists are actually very reluctant to use it. Even if we were to say, go ahead, it's interesting. Like if people get colitis, they have no problem using it. If they get hypophysitis, they have no problem using it. But I think because we've made them so afraid of the myocarditis, they really just don't want to use it. And I would agree. I wouldn't give it to someone with fulminant myocarditis, but people with like low level, myocarditis where their EF is unaffected, they're relatively asymptomatic, we should be able to give it back.
Thanks, Sam. So I'm Jim Freeman. I'm one of the electrophysiologists here, and a really phenomenal talk. Thank you so much. Sorry, I was a little bit late. Clinic ran over. Everyone's got AFib.
No problem.
So,
I agree. Everyone does have AFib.
Which actually brings me to my question.
Yeah.
With the ICI medications, we see a fair amount of atrial fibrillation, atrial arrhythmias. I noticed it wasn't part of the diagnostic criterion. And also, I may have missed it earlier, evidence around kind of the rates of atrial arrhythmias, because obviously stroke rates are up, and that could be from vascular disease, but it could also be from cardioembolic sources from atrial arrhythmias. So I wanted to get your thoughts on that.
So in my experience, AFib is not a big player in ICI myocarditis. It tends to be more complete heart block and VF if you're having, cardiogenic shock from it. AFib is more a consequence of CAR T cell therapy. So if you're looking at immunotherapies, I would say that CAR T cell therapy primarily has 2 cardiac toxicities. One is AFib and the other is cardiomyopathy that tends to be reversible. But immunotherapy with ICIs, AFib is not a big player. The drug that I think is the biggest player in terms of cardiotoxicity with AFib is the BTK inhibitor. So ibrutinib, acalabrutinib, zanubrutinib. And there it's been a big thing, right? How do you manage these people? Because sometimes the AF can be very refractory. It can increase their risk for both stroke as well as heart failure in particular. And then I know that within the EP community, there's a fair amount of controversy about whether ablation is equally effective in these people because the drug promotes sort of fibrosis of the atrium and whether or not mechanistically ablation would be equally effective. But I would say that's been my experience. I don't know if you guys have seen a lot of AFib with ICIs.
Agree. The big players, as you said, are going to be the ventricular arrhythmias and the heart block. We see it. It's hard to know, as you said, like, is it primary component of inflammation and the myocarditis versus, secondary to all the physiologic response. we have some like ongoing evaluation of looking closer at the left atrium in some of these cases with some MRI techniques to look at like inflammation and fibrosis, and a small number of patients. We're still kind of evaluating that data, but anecdotally, like sometimes they have delayed enhancement of the left atrium. And in a small cohort that we looked at, it looked like maybe there might be some correlation. But it's hard to know. And I'm sure it's probably a mix of both.
Both
Like you
things,
said,
yeah.
everyone is AFib. So,
Yeah.
that's two answers about that.
I don't have much to add to that. I agree. And I would say just, in addition to the very apt statement, everyone has AFib. I think in the case of patients with advanced malignancy, like that's even more so just in general. Like I feel like in residency, I learned to manage AFib on oncology rotations.
Yeah.
Because if you think about it, it's typically when patients are getting treated for cancer, malignancy itself leads to a hypermetabolic state. Often you're in a hyperadrenergic state, either because of exogenous or endogenous factors. The anorexia and nausea that come with a lot of therapy lead to hypervolemia. So there are all of these catecholaminergic drivers. Again, both things intrinsic to the malignancy and things related to what we're doing. And so I think as a general rule, if a patient is receiving ICI therapy and they have any new arrhythmia, the question should at least be raised. It doesn't mean like, oh, they have myocarditis, like we have to stop, but at least it's something that warrants potentially a phone call to one of us to discuss, because we would want to have a reason, but to everyone, all the points that have been made, there usually are lots of other underlying reasons why cancer and cancer treatment in particular tend to be sort of pro-arrhythmic states.
I would agree.
Can I ask a question? Very interesting talk. When you mention the LAD is more sensitive to irradiation, do you suggest that's like arterial endothelial cells sensitive to irradiation? You would think a microvessel endothelial cell may be more sensitive to irradiation. So what are your thoughts about this LAD irradiation sensitivity? What are potential endothelial damage biomarkers you could imagine for this irradiation endothelial damage aspects?
So I think, we did show that microvascular disease, microvasculature is affected by radiation, right? I showed that PET study where we showed decrease in both global myocardial flow reserve as well as in the individual coronary territory. So it's a global phenomena, but just in terms of which territory predisposes you to a higher risk of cardiac events, it's the LAD. And primarily, I guess, because of what it supplies, right? If it supplies your anterior wall, then presumably if you damage that, you're more susceptible to having adverse cardiac events. But I don't think physiologically there's any difference in which part of the heart is being affected.
Okay, thank you.
Yeah.
Ajay, one last question. It's great seeing you.
Thank you. Nice to see you. Sam and I
Practic-
were medical students together, even before residency.
That's how old we are. I'm still older than you are. A practical question about biopsies, because as the interventional cardiologist, we're asked to do some of these sorts of things. We've unfortunately had a few bad outcomes. Practically speaking, how do you really use biopsies and, in terms of changing your management decisions?
So I think practically speaking, in majority of people, we don't do biopsies because you can make the clinical diagnosis. I think the time that you do a biopsy is where really you are uncertain, right? So like someone who has, let's say, a troponin of 100, so it's high, but it's not like super high. Their EF is normal. They have some symptoms, and no disrespect to cardiac MRI, but if you say suspected ICI myocarditis, they all find like some edema, some, high signal, could be consistent with clinical correlation recommended, right? So you can like fit the clinical criteria if you want to, right? So I think in those cases, especially if like the person also got massive doses of anthracycline before, if they have some other reason that you think there could be a non-ICI mediated cardiac dysfunction, right? And you really don't want to deprive them of ICI therapy. That is when I push for a biopsy, but it's rare in today's day and age. Yeah,
So in patients that undergo ICI therapy.
yeah,
They don't have much cardiac, but they have sign of coronary artery.
yeah.
Ever thought about books?
So no, I mean, we haven't. I think we've been giving that to people with just isolated ICI pericarditis. So, you can get ICI pericarditis without myocarditis. And in those people, we use colchicine quite liberally. The coronary artery disease thing, I mean, we would treat them like we would anybody else. So if you wanted to give them colchicine because you believe in, you're like progressive, proactive. No, I am, but I can't say that I have reached the polypharmacy level yet where I'm giving everybody colchicine. But exactly, but we haven't done it, I would say, but it's something to definitely think about. And I think the ICI mediated atherosclerosis is still something that is under investigation. It's not something that is yet proven, but arguably they would benefit from colchicine. I agree, but that's not something that I think is commonly done yet in clinical practice, right? Would you agree? Yeah, yeah. Yeah.
Oh, thanks, Dr. Noria. I just had a question about the survival data in the newer cohort, like the contemporary cohort with myocarditis. I think, we've seen a lot that a lot of the patients who have immune-related adverse events also have sustained response, even with discontinuation of therapy. So I was wondering if you looked at people, like what the causes of death, whether they were cardiovascular or related to cancer therapy, and what was their response at the time of discontinuation?
So at least in that 1 year data that I showed, majority of the people had cancer-related death. So it wasn't, so they did have, even though they have a response, many of them, I think many of them end up, not having as sustained a response as you would think. Thank you. Thank you for inviting me.
First of all, thanks for joining us and welcome back home.
This was awesome. Thank you so much.
Which is good because I'm not going to be here. There's a few, I'm going to probably be missing a.
I think it might be the, I am so confused by this. That feels so bad because,
I think Kathy had linked it in the.
yeah, I'm trying to find where the screen is. View. Because I'm trying to go to like off the Zoom screen so we can leave this maybe.